There I am. Hey, there's an actual person talking to you. It's not just a robot. Awesome. Well, hey, y'all, it's 8 o'clock in Texas. I don't know what time it is where y'all are from, but it's time to get started. So I wanted to, just before we really launch into this case here, thank y'all for joining us, and thank you for communicating with us about where you're from. And I think it really helps to build the community. And in that regards, I was kind of feeling inspired to just give a warm thank you to everyone for what y'all do. Not necessarily like with regard to Medgeeks or anything, but just working in medicine in general. I had a really, really rough, really couple of weeks, but it was like a couple of really tough shifts in the emergency department, managing some cases that were really stressful, really emotional. And I was just feeling kind of down and feeling kind of drained after that. But, when you talk it over with some friends, you talk it over with people who understand what you're going through, talk it over with family, they really help pick me up. So I don't know where y'all are at right now, but hopefully, you have someone in your life too that you can talk to help pick you up, because it's hard practicing medicine. I mean, the knowledge base that you need to practice medicine obviously is challenging, but just the emotional aspect of dealing with patients who can be so challenging and so stressful, and it's your job to be there for them. And you don't just have one patient, you have like one patient every 10 minutes sometimes, and you just get swamped with taking care of people, and it's tough. So thank y'all for what you do. I don't know your exact situation, but I know whatever you're doing is probably not easy, because medicine is just not an easy thing to do, but you do it and your patients are better for it. So thank you. I'm going to go ahead and get started here. This is case number 4. So this is the 4th one of these now. This is a really interesting case. I will say this is probably the rarest of the 4 cases that we've done so far. So I hope we all learned something today. Let's go ahead and launch into this. This is kind of an outline for what we're going to do. If you haven't been with us before, it's a case-based, but we're going to try and make it educational along the way. I want it to be interactive. So I put a little note here at the beginning. As we're going through the history, the physical exam, you're going to start formulating a differential diagnosis. Send them in on the chat box. There's going to be a little delay before I read them and then, can address them. But go ahead and send them in as you've got differentials, and include what stuff you want to order as well. As if you were seeing this patient and you wanted to put in orders for imaging or labs or whatever. Okay. So here's the case. 57-year-old male presents to the emergency department for the 2nd time in 3 days, and his complaint is left flank pain. So already off the bat, we have a red flag. He's a bounce back patient, right? Bounce back patients are a unique subset of population. A lot of times it's just kind of like no big deal that it's a bounce back, but a lot of times it can be a pretty big deal that they're coming back to see you. So let's look at more. So his pain, this left flank pain, was acute when it started. It came on really quickly, and it's been constant ever since. And he also complains of the symptoms of nausea, vomiting, and fever. He's got no recent trauma. He denies any chest pain, no shortness of breath, no abdominal pain, and no hematuria. No hematuria. A little bit more history here. He had a prior visit 3 days ago for the exact same complaint. When they worked him up in the emergency department, they found that he had signs of an acute urinary tract infection. So they put him on some antibiotics and discharged him home. He also had a CT, a non-con CT of his abdomen and pelvis, basically looking for a kidney stone. Didn't find one. And he was discharged home on Cipro for the UTI. He's had no improvement since that time. So that's why he comes back today, 3 days later. So y'all have probably seen this before, wherever, if you're in an emergency department or outpatient, it's a bounce back patient. It makes you nervous a little bit because you're like, all right, maybe this person's a little sicker than initially we thought. And there's some things that are jumping out here. He's got constant pain. This guy was pretty uncomfortable. He was an actual patient I saw. This was probably like 7 or 8 months ago. And he was very uncomfortable appearing. So I was a little nervous just straight off the bat. Here's a little bit more about his past medical history. He's got type 2 diabetes, and hypertension, no prior surgeries. Lauren is saying, I had a patient present this way Tuesday, except she had abdominal pain. Yes, exactly. Very common bounce back scenario. So, this guy's a diabetic. He's hypertensive. Diabetics, it's kind of my thought that diabetics try to make you look bad in medicine. Sometimes they don't present the same way. Diabetes is just a risk factor for just about everything. I'm always super worried about diabetic patients. Even if they look okay, they can be pretty sick. So here are the medications that this guy's on right now. He takes lisinopril, metformin, glipizide, and the Cipro, the aforementioned Cipro. So he's on day 3 of 7. He has been taking the Cipro as prescribed. That's a super important question to ask pretty early on when you're talking to these bounce back patients. Did you take the medicine we asked you to take? Because a lot of times they haven't. We'll see that a lot with like skin infections or something like that, cellulitis or an abscess. Patient was prescribed antibiotics and they didn't take it, so they bounce back. Well, it's like, okay, you haven't been taking the antibiotics. No wonder it's getting worse. So, but in this case, our patient had been taking it. So here's the ROS. He's got fever, left flank pain, nausea, and vomiting. Everything else was pretty much negative. Nothing else on there. And then his physical exam, here, vital signs first. He's got a temp, 100.7. So this is, it's not just a subjective fever. His temp is elevated here. Heart rate's 96. Respiratory rate's normal. His blood pressure's up. He does have a history of hypertension. So, that's not necessarily the biggest worry I have when I look at this guy. I would say the temp and the heart rate and the fact that he's having continuing symptoms despite treatment after a presumed UTI workup 3 days ago. Blood pressure could go up for a lot of reasons, though, especially in a person who's hypertensive at baseline. Maybe his medications are not adequate. Maybe he hasn't been taking his medicines. Maybe the pain is causing his blood pressure to go up as well. So that's how I interpret these vital signs right here. But definitely the temp is concerning because that's not normal. So here's his physical exam. Thin male, mildly distressed, and that was just due to pain. And then tenderness to the left flank. So it's kind of that costovertebral angle region that you would expect for, pyelo or kidney stone, something like that. Gilbert saying, I wouldn't worry much about the heart rate. So what was the heart rate? Like 90 something, 96, I think it was. I don't put a whole lot of stock in the very first heart rate. I actually carry around a little pulse ox in my white coat when I'm in the ER, and I check people's pulses all the time when I go see them because triage vitals can be very telling, but a lot of times they're high. Their heart rate's a little high. So I always recheck it when I get in the room. And this could be just 10 minutes after triage, and maybe his heart rate went from 96 down to 74. And I just asked the nurse, hey, can we document a new set of vitals, or at least the heart rate, because his heart rate's not in the 90s anymore. We got some questions here. Let's see. Did he have any prior issues or recent travel? No prior issues prior to 3 days ago when he developed the flank pain, and no recent travel either. Last bowel movement, I don't remember specifically. I believe he had been having regular bowel movements, nothing abnormal, no constipation, no obstipation, no diarrhea, no blood in his stool, no melena, no vomiting, just the nausea. Or did he have vomiting? I think he might have had vomiting, but it wasn't like a continuous, constant vomiting. Okay. Here we go. What are y'all's differentials? I saw a few things earlier, and then we'll talk about the workup and we'll do some labs. I saw something someone sent in, like a renal abscess. That's an excellent thought, especially when someone's having continuing flank pain. They've got fever. They're a little tachycardic or borderline tachycardic for sure. Let's see. Someone else put something else down lower. Let me look and see. Renal abscess. Oh, Jane said mesentery, like a mesenteric ischemia. I think that's what you're saying there, or what you're referring to. That's a good thought as well. Renal cell carcinoma for sure. I don't know how often that presents with pain or fever, but definitely a consideration when you're having any sort of renal issue that's not responding to the expected therapy. Don is asking about African American sickle cell with renal manifestation. This was a white male, Caucasian male. Laura Lee, adrenal mass, possibly, absolutely. Stephanie says, well, we know not kidney stone or pyelo. Yeah. For one thing, that would not make for a very interesting case presentation this evening. So it's definitely not that. Maybe prostatitis, says Lisa. Maybe diverticulitis. Radiolucent stone. Okay, so we got a lot of ideas out here. Brian, the CT scan did not show any hydronephrosis. No blood cultures have been done yet. Could be diverticulitis, as a lot of people referred pain from GI source. Absolutely. Y'all, the flank is just one of those things. Flank pain can be like anything. It could be pain from below. It could be pain from above. It could be pain from the kidney right there where the flank is. It could be pulmonary. It could be cardiac. It could be all sorts of stuff. So flank pain is sometimes kind of obvious, but other times it could be just about anything. So let's move on. I think we're good to move on to here's kind of I don't think it includes everything that we had mentioned or that y'all had mentioned. Y'all came up with a few good ones that I didn't have on my list, so nicely done. But here's kind of the working differential that I was operating under as I was seeing this guy. Obviously, pyelonephritis. So last time he was there, and I'll show you the labs from the previous visit here in a second. But pyelonephritis is definitely a concern. Maybe this is a UTI that's resistant to ciprofloxacin. So maybe, even though he's taking it, it's just not the right drug for him. Renal colic. They did do a CT scan last time. Perhaps it was a radiolucent stone. Perhaps the CT scan just missed it, which is extremely rare, but you never know. But I kept it on the differential just to think about because it's flank pain. AAA, abdominal aortic aneurysm, absolutely could be causing. Usually, the classic is that it's formally more abdominal pain, pulsatile mass, etc. But certainly, if it's rupturing, especially, it could radiate to the back or the flank area as well. Something to consider. It was not seen on the CT scan from 3 days ago. Did not show any sort of AAA. Bowel obstruction or perforation could definitely refer pain to the back. PE, since this is the flank is kind of that border region between the abdomen and the thorax, the upper lungs and so forth, could definitely cause that. Muscle strain, I pretty much always think someone could have a muscle strain just because they can. You can't think of anything else or can't find anything else. It could be they slept on it wrong or muscle issue. Again, wouldn't make for a very interesting case presentation, but it's on here. Pancreatitis, peptic ulcer disease, a pneumonia to the left lower lobe, obviously. And then ACS. Is this guy having a heart attack? Be kind of a weird place to have pain, but it's not unheard of. He does have hypertension and diabetes, and he's not young, so it's definitely something to consider. And then shingles. Always got to look at the skin. Undress your patient. Look at the skin. See if it's shingles. So let's continue on. And what you'll remember from the physical exam, we didn't see any rashes at all. I know that the pain with shingles can come before the rash, but in his case, it turned out to not be shingles. His pain was a little bit deeper too. It wasn't that super, irritated, hypersensitive sort of pain that you get with light touch of the skin. It was a little bit deeper. Okay, so here's the workup that I started with. Labs, pretty basic labs, CBC, a CMP, lipase. Definitely want to check his urine to see if there's anything abnormal there. I got a troponin on him just regarding ACS just to make sure. Imaging wise, I also ordered an EKG, chest x-ray to look for any sort of pneumonia or free air under the diaphragm, anything like that. Now the question comes, CT scan, ultrasound, what sort of advanced imaging do we want here? I'll tell you what I did later. For now, let's just start with doing, I won't tell you. We'll just do the lab. We'll show what the lab showed, and then we'll go from there. So we got people here are asking about a urine culture from the last visit. A lot of people honing in on the spleen. Very smart. Yeah, you can get a splenic rupture. Usually that's traumatic. Splenic hematoma, just splenomegaly in general can cause left flank pain, right? So anyway, guaiac test, rectal exam, those are all good things to do to see if there's any evidence of like a GI bleed, maybe from diverticulitis, maybe from an upper GI bleed. D-dimer, obviously we'd be trying to rule out a pulmonary embolism from there. I did consider ordering a dimer on this guy. It was kind of in the back of my mind as like maybe a second line test if we didn't find anything on the first pass. Wound up not needing to do that. Here's the EKG. This EKG is essentially normal. So nothing going on here. It's a normal rhythm, normal rate, about 68 beats per minute. Everything looks good. No signs of any sort of ischemia at all. The T waves look good. The ST segments look good. No depression. Looks good. Let's continue. Here's the chest x-ray. I'll let y'all look at that a second. Looking for any sort of like infiltrate. I usually look at the outside first. I look at the borders and see if there's anything like a pneumothorax. Then I'll look at the diaphragm, see if there's any free air under the diaphragm. There's not in this case. And then I look at the interstitial markings, see if there's any sort of infiltrates, any widening of the mediastinum, cardiomegaly, signs of CHF or something. Everything looks good here. And that seems to be what everyone's consensus is here. Pretty much a normal chest x-ray right here. Nothing going on there. No free air, no infiltrate. Okay, let's continue. So here's where we get into comparing the labs from his visit 3 days ago and today. So 3 days ago on his CBC, he had a white count of about 13. Today it's 12-ish. So nothing scary about that. I mean, when they were here 3 days ago, you could certainly get a white count of 13 if you've got a UTI or even like maybe early pyelonephritis, which is kind of what they were thinking. I'll show you their UA from a few days ago in just a second. I probably should have started with that actually. But basically, when you see the CBC from today, the fact that it hasn't jumped up, the white count hasn't jumped up from 12.9 to 19 is pretty reassuring. It's actually gone down a little bit, so essentially unchanged. Here's the CMP. Really, the only thing abnormal 3 days ago was the glucose of 250. This is a diabetic, so maybe they're not watching their diet like they should, or their medications are insufficient, something like that. But the important thing 3 days ago and today, even though glucose is elevated, the bicarb's normal. Of course, when we read a CMP, we're looking at what actually says CO2, but that's a marker for bicarb, which is normal. If this patient were acidotic, you'd expect that to be a little bit low. People are starting to recognize what I was just about to say, and that is that the creatinine has bumped up a little bit. So creatinine was 0.8 or normal 3 days ago. Today it's gone up to 1.3. So what are some reasons that could happen? Obviously, you know, we think about kidney function here and it's decreasing in this patient. That's what I was thinking when what Anne just said is that maybe he's dehydrated. You know, he's been having nausea and vomiting. Perhaps he's just not getting the fluids that he needs. So he's getting a little bump in the creatinine. That's fairly common. So good thought there. Could be something wrong with the kidney though. That's the primary issue as well. So cool. Let's move on. Let's look at the urine. Oh, before that, here's the lipase and the trope. Both are normal. So pancreatitis is out with the normal EKG and this troponin. I think ACS is pretty much out as well, especially since this has been going on for 3 days now. we would definitely expect the trope to respond in that time frame. So here's the UA. So this is from 3 days ago. You see the leukocyte esterase was moderate, and there was some bacteria present as well. So, I mean, I can totally see where if the entire workup is negative, except for this, which was basically the case, like a white count in this and a clear CT. I mean, yeah, treat them for a UTI, send them home, see if they get better. If they don't, if they're getting worse, ask them to come back to the ER. And that's exactly what happened. So I don't think bounce back patients, I always get nervous when one of my patients bounces back to the ER because it's always like, oh gosh, what did I miss? What did I do wrong? What did I miss? And in this case, I'm not here to judge the person who saw this person before me, but I will say that I don't think they necessarily did anything wrong with their workup. I probably would have done something similar, especially since their pain was controlled and so forth. People are saying, Angel says, was the CT with contrast could cause AKI. It was a non-con CT 3 days ago. But that is a very good thought because sometimes contrast can cause an increase in creatinine. Apparently, I've been reading up on that lately, actually. Apparently, that's a little bit of a debatable fact that some radiology people think that we should be less worried about contrast-induced AKIs, but that's not the subject for today. I think for now, definitely consider any sort of IV contrast to be a possible cause of AKI. Glomerulonephritis from Cipro, possibly, absolutely. Oh, Victoria's asking what the GFR was. The GFR was, I think it was like in the high 60s. Yeah, it was somewhere in the high 60s. Okay, here's the UA from today. So what do y'all notice is different about the UA today? Obviously, y'all can read it, but what do you think that means? How would you interpret that as far as, is this pyelonephritis? One of my thoughts when I saw this patient was, okay, they're having worsening flank pain. They were treated for UTI 3 days ago. Maybe they're not taking the antibiotics like they should, or they're not effective. But this kind of tells us that that's probably not the case, right? I mean, the leukoesterase is now negative, and there's no bacteria. We do see some protein. There's some protein in the urine. There's some ketones in the urine. That I would imagine, obviously we think DKA when we hear ketones. However, their sugar was less than 200 and they did not have an anion gap. Their bicarb was normal. I don't think I'm not thinking it's DKA at this point just because of what the chemistry showed. And now we've got some blood in the urine too. So people are saying definitely some ketosis, RBCs, says Dawn, and protein, maybe DM2 causing problems. Absolutely. Absolutely. Let's move on. What do we have next? Oh, I think someone asked about the urine culture from the prior visit. They did do a culture, and the culture showed no growth. So again, pointing to the fact that this is probably not an infectious problem, at least not a kidney infection. All right, good deal. So we are at the point where here, this is our original differential diagnosis that we started with. And I feel like these are the things that we can pretty much eliminate already at this point. So pyelonephritis, let me know if you disagree, but I think we're probably ruled that out at this point. The UA looks great today. The culture from 3 days ago is negative. They've even been on Cipro just to boot. So their flank pain is probably not a kidney infection or even like a cystitis that is referring up to the kidney area. Oh yeah, good point, Andrew. There's no sign of any sort of rash. I forgot to mention that, but yeah, I did look at the skin. No sign of shingles or anything like that. So we can cross that one off too. I just didn't do it. But in your mind, cross off shingles. So what are we going to do about these other things? What are we going to do about this, possibility of the other things on our differential, the things that are written here, and the things that y'all are throwing out as well as possibilities? My next step was imaging. So I wanted to get some imaging. We do that a lot in the ER. Image it. I don't care. CT it. Just CT the thing. So what imaging, if y'all were going to get imaging, what would you want to get? Keep in mind, 3 days ago, we had a CT scan that was non-con CT of the abdomen and pelvis, was essentially normal. Didn't show anything going on with the kidneys or anything else for that matter. No evidence of a AAA. It was without contrast, so probably not the best study for a AAA, but usually if there's a AAA, you can see it even on a non-con CT. Not the test of choice, though. People are saying ultrasound. I like that. Ultrasound. For sure, MRI. Can't go wrong with an MRI. Okay, let's talk about options. So CT of the abdomen and pelvis. You can always just repeat the CT. You know, it's not always what you need to do, but in a patient that looks the same. In this case, we would probably want to add IV contrast. So that's definitely a consideration since the last one was without IV contrast. Renal ultrasound. A lot of people are voting for the renal ultrasound. This is a decent option for sure. It's going to show you any sort of potential masses. It's going to show you any signs of inflammatory changes, hydronephrosis, things of that nature. So that's definitely a consideration. CT aortogram. This would be specific. This is kind of the gold standard for looking for a AAA. So if we were super concerned about a AAA, the CT aortogram would be the test of choice, although a CT abdomen and pelvis with contrast is also helpful. And then a CTA chest. This is if you're thinking, like a PE. I didn't order the dimer in this patient. I was thinking less that this was a PE. The patient's heart rate had come down a little bit, I think, before I ordered any sort of imaging. And I wasn't thinking PE. They weren't having pleuritic chest pain, no shortness of breath. It was really just in that flank area. Plus, we saw the findings with their creatinine going up and so forth. So I thought something was going on with the kidneys. But there was still a chance in my mind that it could be something bowel related, like maybe a small obstruction or something like that, or perforation or something going on with the spleen. I was thinking something like that, and I wanted to rule it. Like the renal ultrasound wouldn't do anything to help us rule out anything else. So since this guy was looking worse, what I ordered was a CT with IV contrast. People have mentioned the creatinine going up and how that's you're potentially gonna give this guy an AKI or make his worsening renal function worse with the contrast. However, I felt like it was the best option. I did talk it over with the attending physician I was working with just to see what their thoughts were. And they said it's going to probably give us the most answers as far as ruling out a lot more things than a renal ultrasound would. However, I don't think you'd be wrong to do a renal ultrasound necessarily. You just may not find what you're looking for. You may not find what it was. But anyway, let's move on. So here is what we got. This is the findings from the CT scan. This is a CT of the abdomen and pelvis with IV contrast. And basically the answer was revealed to me when we got this CT scan. So full disclosure, it wasn't even fully on my radar when I ordered the test. However, what we can see here is the second bullet point here in the left kidney, wedge-shaped diffusion defect. So what does that mean? What that means is there's kind of like you're not seeing appropriate blood flow through a certain region of the cortex of the kidney. The parenchyma of the kidney was not getting perfused well. So what that is, and there's no stones, there's no hydronephrosis. The remainder of the abdomen looked great. I didn't put it on here. The spleen was fine. Appendix is normal. The aorta was normal as well. Here's an example of a picture of what we're talking about. And so this is a renal infarction. I think someone mentioned that. Yeah, multiple people are saying that. So yeah, this wound up being a renal infarction. So very interesting is what I said. So let's talk about renal infarctions. This is what this patient wound up having. Basically, any sort of problem with the blood supply to the kidney can cause this. So tissue destruction within the kidney due to a compromised arterial blood supply. People have been mentioning renal artery stenosis. That definitely does cause diminished blood flow to the kidney. I don't know that it would cause an acute infarction, though. They may have renal artery stenosis, but generally speaking, that's more of a chronic, slowly developing thing. This is a renal infarction is often missed just because it looks so similar to pyelo. It looks very similar to kidney stones as well. Occlusion of the renal artery or one of the smaller segmental or even subsegmental arteries as well can cause this. And this can actually happen bilaterally as well. So up to 16% of the cases of renal infarction are bilateral. Okay, so what causes this? There's two major causes. The first one, everyone's talking about embolism. That would be the first one. So thromboembolic would be one of the major causes. So meaning that somewhere there's a clot and it broke off and it's flowing through and gets lodged in the renal artery or somewhere into a smaller artery. Could be from the heart, could be from the aorta. A classic would be an AFib. So you're throwing clots from AFib and they gotta get lodged somewhere. So they get lodged in the renal artery. Patients who have hypertension, diabetes, history of endocarditis or artificial valves are at higher risk for this as well. The other kind of cause that would be potentially present is in situ thrombosis. So either this patient has some sort of hypercoagulable condition that's causing them to form clots within the kidney itself, not in another place that got thrown to the kidney, or renal artery dissection or some sort of injury. So that's what, those are kind of the main causes of renal infarction. Signs and symptoms. So let's talk about kind of like how you don't miss a renal infarction. Signs and symptoms. This was based off of a study that they did a few years ago. 438 patients who had a confirmed renal infarction had these symptoms and signs. So 50% of them had flank pain. 17% had nausea. 13% had vomiting. And 10% had fever. Even though it's not an infectious process, it's kind of curious. Maybe someone can help me understand that, but definitely interesting. It was low-grade fever. Elevated blood pressure also. So, I mean, this guy had a history of hypertension, plus he was in acute pain. So that could have been raising his blood pressure. But if you have a patient whose blood pressure jumps up, it could be because it's thought to at least be because you're activating the renin, angiotensin, aldosterone system. You know, remember the kidneys will release renin in response to the poor perfusion. So that is one of the reasons that it's thought to cause high blood pressure. So labs, what are we going to know from the labs? What's going to help us out? Based on that same study, 32% of the patients had hematuria, 12% proteinuria. Creatinine can be normal or it could be elevated, and it depends on how severe the blockage is or how reduced the blood flow to the kidney is. If it's something like a larger clot or if it's affecting both kidneys, it's more likely to cause an elevation of the creatinine or even a larger AKI. You can also get elevated serum LDH. So the lactate dehydrogenase goes up in response to tissue damage. So since this guy's infarcting, it's not a specific finding for the kidney. Certainly any tissue that's infarcting is going to cause LDH to go up. However, larger incidence, helpful in distinguishing from pyelo and nephrolithiasis. Okay, and then mildly elevated white blood cell count is common too. So that's kind of like the basic labs that you find. As far as imaging goes, this is a CT scan with IV contrast is the most sensitive study for this. So a lot of times when you've got a patient who's got a CT without contrast and it looks normal, that's reassuring because you were looking for a kidney stone. However, without contrast, it's a lot easier to miss these. Renal ultrasound is often going to miss these as well. The sensitivity is much less. So getting it with IV contrast is about 80% sensitive. You can also get a CT angiogram of the kidney. That's usually after you know that they have it, though. And it's going to just basically help evaluate how badly occluded the artery is to help direct management. There's also a radioisotope renography, and that's not a common test we do, I don't think, anymore, but it's very sensitive for detecting this. And then the EKG, the main reason you would want one for a suspected renal infarction is to see if they have AFib. So how would you manage this? What do we do? So there's actually not a whole lot of data out there in order to establish a very clear, obvious next step in management. Obviously, one of the things that you do, especially if you're like me and you work in the emergency department or urgent care or something like that, talk to some specialists, right? You want to consult nephrology, interventional radiology, and vascular surgery. And the reason for that is one of the treatment options is endovascular therapy. So there's two basic approaches to management. One of them is the endovascular therapy. This could be thrombolysis, thrombectomy, or angioplasty. Indications for this would be if there's a complete occlusion of the renal artery, if there's really like a lot of the kidney involved, significant renal parenchymal involvement, or if the patient only has one kidney, you want to be a little bit more aggressive in those patients. Earlier is better when it comes to doing one of these endovascular therapies. You want to do as much as you can quickly, ideally within 6 hours of symptom onset. The other thing is anticoagulation. So heparin and then Coumadin. I think that's what Stephanie said there already. Good call. You definitely want to anticoagulate these patients, and particularly if you suspect that they might be hypercoagulable or have some sort of cardioembolic reason for the infarction in general. Take a look through some of the questions just to make sure I'm not missing anything here. Send in questions, by the way, as we're going through this. Kay Chun says, would contact interventional radiology for renal angiogram. There you go. Yeah, renal artery stenting is definitely an option, particularly if it's early on and if it's involving the renal artery itself as opposed to one of the smaller branches more distally. Cancer or rheumatologic etiology, that certainly makes you more hypercoagulable. Absolutely. I'm sorry. A couple people are having video issues. Let me know if there's still a problem with the video. I'm plugged into the Ethernet here, so hopefully it's still good. In a primary setting, how would you distinguish this from pyelo versus UTI? That could be tough. Could be very tough. Generally, it's really hard in a primary care setting if you're not going to be using any sort of imaging or labs. If you're just looking at the patient and maybe you dip their urine and you see that they have evidence of infection, you kind of treat for infection and go from there. I think if they're not getting better at that point, after you treat them with antibiotics, then you have to raise the level of suspicion for something else going on. If this is a patient in whom you suspect it could be more than a UTI because they've made clots before, do they have a history of AFib? If they've got some sort of hypercoagulable condition like a protein C deficiency, protein S deficiency, factor V Leiden, for example, if there's anything in the history or even family history about clots, it would be time to maybe get the CT with contrast and see if there's evidence of that. You can also, if you were checking labs, you can throw in an LDH because A lactate dehydrogenase is not going to be elevated in a UTI or pyelonephritis. However, if there's any sort of renal infarction, there would definitely be an elevation of the LDH. Or I shouldn't say definitely, but there's definitely more likely to be. Let's see. K-Chun says time is kidney. Yes, that is true. I think that's literally time is kidney as a bullet point on one of my next slides, actually, because you want to move quickly with this. Allison again says, right, so initially treat as pyelo UTI, but then if no improvement, need to consider, yeah, that's probably what I would say. I think if the CT without contrast is normal, or if you treated as suspected pyelo and it didn't get better, then I would consider CT with contrast, or if they've got any of the history like I was mentioning. Jessica, any stats on the incidence of renal infarction? The only stats I saw on incidence indicated that it was extremely low. And that's not necessarily what percentage of patients have renal infarction who present with flank pain. It was percentage of patients who present to the ER in general. But I think the incidence is like way less than 1%. Now, they did mention that the incidence of this is probably falsely low or underreported because it goes underdiagnosed, because a lot of the patients are diagnosed as something else, like pyelonephritis, for example. One study I saw when I was preparing for this said that in a study of 18, I believe it was 18 patients who were admitted to a hospital and found to have renal infarction, of those 18, about half of them, or a little more than half of them, were admitted for pyelonephritis as opposed to the infarction. So that's an example of how this is really easy to miss. It's really easy to pin this on pyelonephritis, because how many times do we get urine samples that are dirty? And you can kind of, if you squint and turn your head to the side and look at it, yeah, that could be an infected urine. That could be a UTI or pyelo, if you need it to be, so to speak, because they really look sick and you think they need to be admitted. So I think that's part of the reason why this goes under-recognized. Let's see. Did I ever say if this was a thrombus or dissection? No, I haven't said yet. I'll let you know what we wound up seeing later. So what management was done with this patient? Yeah, again, I'll show you what we do in just a second. Mary makes a good point. She said, why fever but no infection? I was asking y'all, this is a great point. Fevers can definitely be caused by things other than infection, autoimmune, inflammation, cancers, dehydration. Excellent point. That's probably what's going on with this patient, why fever is common with infarction, or 10% infarction. Why Coumadin and not other anticoagulants? I think in theory you probably could do a DOAC as well, like a Xarelto or an Eliquis. I think you probably could do that. However, like Ann said, Coumadin's cheaper and more common. But I, as far as I know, you'd probably have to talk to a hematologist or someone else just to make sure. But I'm pretty sure it would probably cause the same level of anticoagulation that you needed for this. Pain level on presentation, asks Laura. It's pretty high. I don't remember what the number was. To be honest, I don't usually ask the number, but if I had to guess, it was probably like a 5 or a 6. Like, it was pretty moderate pain. He was definitely uncomfortable. I treated him with morphine because he looked so uncomfortable, and I didn't want to give him Toradol. Okay, because of the kidney function that I was worried about his kidneys from the beginning. But anyway, his pain level was pretty significant. He looked uncomfortable. So management of the renal infarction continued. Let me see. I think my slides look a little weird here. Yeah, sorry. There we go. Continued. So evaluate for AFib on the EKG as well, and evaluate for any sort of hypercoagulability. So look in the history for any evidence of prior clots or family history, and then of course labs. I'm not going to get into the weeds on how to work someone up for hypercoagulability, but this person definitely qualifies as needing that. Okay, so this patient was admitted to the hospital. because of the amount of time that had passed following the symptom onset and the relatively small amount of involved kidney parenchyma that we could see on the CT scan, it was decided that we would not do any sort of endovascular therapy. I definitely mentioned or brought up the thought of doing a CTA of the kidney in order to see like how bad this is or what the scenario really is. And I couldn't really order that in the emergency department because we had already just given him some IV contrast. The nephrologist I consulted said we should wait instead of potentially hurting his creatinine. We were already kind of rolling the dice on giving him some IV contrast just to get the CT scan when his creatinine was going up initially already. So we decided to wait. It was later performed in hospital, though. I think the next day or two, they did the CTA, and it showed that there was no dissection and that the blockage was somewhere in one of the smaller, like subsegmental arteries. So this patient was not a good candidate for any sort of intravascular intervention to revascularize that tissue. Plus, a lot of time had already been passed before that window. This person was put on cardiac monitoring the whole time they were in the hospital. No evidence of AFib at all. So his creatinine did stabilize. It stayed in the 1.1 to 1.4 range. It didn't continue to rise, which was good. And the rest of his labs stayed normal as well. So he was eventually discharged home. So he stayed in the hospital for 3 days. He was on Coumadin. Presumed cause at this point, the hematologist came and saw him and thought that this could be some sort of in situ thrombosis from an unclear etiology. It wasn't exactly clear at the time he was discharged, but the plan was for him to continue to follow up with hematology and be worked up for any sort of conditions that could make him hypercoagulable, because that was kind of the leading idea for what might be causing it in this patient. So I'm going to start going through some key takeaways here that I think are most important to take away from this case. Keep the questions coming on the side. I'll keep an eye on them as we go through. But just to kind of summarize here, renal infarction presents very similarly to pyelo and urolithiasis. So definitely something to keep. Ever since this case, I'm always thinking about it when I have a flank pain. Like if you're ever thinking, is it pyelo? Is it kidney stones? I go ahead and think, could it be an infarction? And I will say I have ordered a few more CTs with IV contrast, even when I'm kind of suspecting it's probably a kidney stone. If there's something in their history or something about, their past. I think like one of the patients I did it for had a history of AFib. So I was like, I'm going to go ahead and do this with contrast, because even it's not an ideal test to do a CT with IV contrast for a kidney stone. You can still see the stone, but usually when you're doing it with IV contrast, they're not following the kidney stone protocol, so the slices are not quite as thin. It depends on where you're working. That may not be 100% true where you're at, so it's easier to miss a really small stone if you're doing with IV contrast. However, that's something that's kind of specific to where you're working and what the radiology protocols are there. Consider renal infarction in patients that have flank pain, hematuria, nausea and vomiting, in which there's unconvincing evidence for pyelonephritis or renal colic. So that's kind of what I was mentioning. Like if those two are kind of knocked off the list of differentials by the testing that you did, consider getting a renal infarction workup. Consider CT with IV contrast if the non-con shows no stone. So I know it's not ideal to just, do two CT scans pre-short succession, but, if you've got a CT without IV contrast and it looks normal, but they still have a lot of bad flank pain, go ahead and send them back to the CT scanner and do it with contrast and see if there's an infarction. I was reading on Up to Date, and that's one of the things that they recommend as a possibility. Increased risk in patients with a prior thromboembolic disease, AFib, or known hypercoagulable state, like I was saying before, factor V Leiden, protein C, protein S deficiencies, that sort of thing. Definitely increase your awareness that this could be an infarction. More takeaways. Treatment options would include revascularization or anticoagulation. Time is kidney, want to move quickly. And then here's just kind of a general note about bounce back patients. So sometimes you've got a bounce back patient who is there all the time, or they're a frequent flyer, right? Where they come in all the time. I feel like the knee-jerk reaction that you have to fight is assuming that, oh, they're just seeking more pain medicine, or oh, they just haven't followed up with the specialist I keep telling them to. They're fine. They're here all the time. Definitely got to fight that, and not just kind of dismiss the fact that they came back, because one of the things I always tell my patients, particularly when it's an abdominal pain or a flank pain or even a chest pain for sure, if it's not getting better, I tell them, here's what I think it is. I think you have gastroenteritis, for example, based on this, that, and the other. But if you're not getting better, or especially if you're getting worse, I need you to come back to the ER. Your labs look good today. Your CT scan looked great today. I can't find any hard and fast, worrisome cause for your symptoms. So I think it's something like gastroenteritis or whatever the case may be for that patient. But I give them that speech because I want them to come back. If your symptoms are getting worse, come back. So in this case, that's what this guy did. He was told, if you're not getting better, come back. And that's exactly what he did. So when that's the case, you kind of have a lower threshold for doing a little bit more testing, or maybe going, a step above where you were before. So that's my spiel on bounce back patients. Okay, what questions do y'all have? Still got a few minutes here before the hour is up. Do y'all have any other questions? Definitely send in y'all's questions if you have them. I'm going to jump up to the next slide and just talking about one of the products we have at Medgeeks. So In the Know is what it's called. Now, a common question we get asked all the time is, how do you stay up to date with things that are always changing, right? There's constantly changes in how we're supposed to manage things. And we get asked all the time, how do you keep on top of things? How do you stay up with the latest trends? So that's why we created what we call In the Know. Every month, we research, review the literature, and bring you the latest, bring you the updates that impact your practice, specifically focusing on primary care and internal medicine. So that's why we created this. So as a member, you get reviews and summaries from the most recently published papers, and each topic is reviewed, identifying pearls. We give you advice so you can implement it in your practice. So that's the whole idea, is to actually change your practice. So this is all presented in an easy to stream audio format. You can listen to it while you're doing other things. You can actually download it, keep it accessible, and you can keep those recordings from the past as well, as long as you're a member. So Andrew just put up the link over in the comment section. If you're interested in that, super helpful resource. Really cool. And here's the cool part. If you don't like it, just let us know. You have a 30-day period, money back guarantee. If you don't like it, send us an email, say, hey, it's not as good as I thought it would be or hoped it would be. I don't want to do it anymore. And we'll give you your money back and we'll cancel it. Don't worry about it. So you really have no reason not to try it if you're interested in something like that, where you want the latest, you want the up-to-date information. And we try to do a good job of making that accessible to y'all through the In the Know. So let us know if you're interested in that. Let me see if there's any questions. Thank you all. A lot of good feedback from this episode. That's cool. Elizabeth, I don't do ER medicine. Could you not just order CT with and without on initial workup? You absolutely could do that, Elizabeth. Yes. I don't routinely do that. For most conditions, I usually just pick, do I think they need contrast or not? But I think you could. Yeah. Usually if I'm doing with and without, it's something like an MRI of the brain, that sort of thing. But you could absolutely order it like that. Stat in the ER as well. You can just get both. Cool. All right. Well, thank you all again for joining. Let's see, I got another slide here as well. It's medgeeks.co. Here's the website right here. This is how you can link to all of our stuff, basically. We're on Facebook, we're on Instagram, we're on YouTube. We got a lot of videos on YouTube, so definitely check us out there on our channel. Of course, the podcast, I'm a little partial to the podcast because I host the podcast. If y'all go to askmedgeeks.com, which is a little different, it's a different website, askmedgeeks.com, that actually sends questions that I review and answer on the podcast. So if you have board review questions, you're studying for whatever board exam you need to take, whether it's the PANCE or whatever, or even the PAN-RE, or your medical school boards, NP boards, whatever it is, send in questions because I love getting feedback on the podcast, and I like the podcast to be super relevant to everyone who's listening. I want everyone to get the most out of it. So send in the questions, follow us at Facebook, and that is our website. And you can find out more information about our In the Know program product. If you are interested in that, we've got the link above the chat box right now, medgeeks.co/in the know. And then you can also just go to our regular website. We've got links to it there as well. Again, 30-day money-back guarantee if you don't like it. So no sweat if you don't like it. Oh, yeah, I also wanted to, Andrew just mentioned no support questions to askmedgeeks.com. So those questions come to me. If you have an IT question or you're having trouble with your membership or something, if you send it to askmedgeeks.com, it comes to me, and I have no idea what to do about that personally. But there's definitely from our main website, you can email the support. There's a link for support, so you can go there if you have questions. Oh, there's the email that Andrew put up, support at medgeeks.co if you have those types of questions. All right. So I believe that's it. So if y'all have any other questions, I'll kind of hang around for just a few more minutes. But otherwise, I really appreciate y'all joining and participating. We're going to do another one of these at some point in the next month or two. And we'll definitely send out information to y'all via email and so forth to let you know when it's going to be so that you can join us. And I think that's it. Y'all have a great evening. And again, thank you so much for joining.